Hello everyone. So I've just introduced the presentation. Karen Sankey is the founder and CEO of the Community Care Collaborative. She'd spent 25 years working as a GP and got to the point where she was just going to quit being a GP altogether. 10-minute consultations with patients meant that lots of vulnerable people weren't having their needs met. And then Karen then started developing a new model of working, aiming to make general practice more sustainable, not only for the patients but for staff and everyone involved. The realisation that the GP had become the key professional that everybody referred into for absolutely everything, when in reality only about half of the issues that somebody comes to a GP for can actually be dealt with by the GP. It's usually somebody else and it's not a medical need. These services were then spilling into the ambulance services, the police and the emergency department. Research was carried out and it gave light to the situation further that actually only 10% of what somebody attends a GP practice for is actually a health need. Everything else is more community linked or family and housing. So looking at what we currently provide in healthcare, it was noted that we often put somebody into a box, so such as what's on here, the lonely club, and you have to fit a criteria in order to attend it. We don't actually think about what their needs are. You could be categorised due to age, area, or the severity of your condition. So patients that often attend the GP practice say that when they're trying to get an appointment, they can ring and ring and ring. That compounded with somebody who's actually homeless, not got a mobile, can't ring for a GP. That could mean that they just can't access a GP at all. Also, there's quite a negative attitude of a lot of professionals and the wider community with regards to homelessness. So that's quite a lot for somebody to overcome when they're trying to obtain the help they need. And then a culture is being created where we do everything to avoid risk. So then the thought process for the model came, could we actually start manage them risks, risk-benefit rather than, avoiding all the risks? And that's where the model came from. So there's a creation of a demedicalised biopsychosocial person-centred service, integrating teams, effective signposting and social prescribing, and allowing for greater access with less eligibility criteria. Focus is on engagement and education and empowerment. So what would the perfect service look like? That's how it all begun. It led to the belief that there'd be need for like-minded people who wanted to work differently and make a difference. It started in 2017 as an informal network. Then Capacity were met, who are a business who enable groups to build upon the work that they've got. So then Community Care Collaborative became a legal entity. They chose a community interest company model because it enables us to have a non-hierarchical staffing structure. It's not a for-profit organisation and currently being converted into a partly employee-owned business so that everyone has a share and a voice in the business. At this point, Karen had a fantastic model, the legal entity, but no way of delivering it. So in summer of 2017, Wrexham was highly publicised in the social media for spice use and homeless and addiction. Wrexham, compared to how many people live in Wrexham, we've got the highest prevalence for homelessness in the whole of Wales due to our smaller population size. Discussions were held with some of the homeless guys and the health manager for mental health, and it was quickly realised that homeless guys weren't able to access the GP or the mental health service. So in the summer of 2017, Karen and the mental health nurse went and joined the Crisis Cafe in Wrexham, which is the council and the DWP were there. They were there for about 6 months, but it was realised that there was a culture that wasn't really right for the vision that she had. Some of the guys weren't allowed in unless they were using a service. They weren't allowed food when they were in there, and they weren't allowed in if there was no family connections or local connections to the area. So then it was decided that they would partner with the Salvation Army and move to their premises, which was in January 2018.
Thank you. So I'm going to talk a little bit more about the Community Care Hub. Are we on the right one? There we go. So the name was rebranded to the Community Care Hub, and this provided an opportunity for the model to be tested. The decision was made to really not have any rules. Karen doesn't really like rules, does she? So we've obviously got safety and governance procedures, but you know, on a day-to-day basis, and it's just sort of 2 years, there's no real need for many rules. We've got 2 lovely 70-year-old bouncers on the door that seem to man the fort, don't they, which is really good. So that works really well. And it's Karen's vision is just to have a truly holistic approach, and that was put in place. And that approach is still used today with many valuable services all under the same roof. There's frontline staff that are trained up to become advocates for the people using the service, and they're able to spend time and talk to the individuals about what they actually need. And these care navigators also have local knowledge, and they're able to link in with people and get them access to the right services. In order to be a care navigator, a diverse selection of staff have been employed. We have a private counsellor, we've got somebody with lived experience of homelessness, and we've got someone who's actually going through recovery. So there is a wide range of different types of people that work with us. We've got an emotional wellbeing team, a care coordination team, which myself and Beth work in, all as part of CCC. And we attend the hub on a weekly basis to ensure that the patients are getting bespoke care plans. And the emphasis really is on partnership working with as many partners involved as possible. Everybody's under the same roof. When I first attended as a district nurse, it was absolutely amazing that I could actually walk into a room and find everybody. If I needed a GP, there was a GP. If I needed a chiropodist, a dentist, everyone was under the same roof, which was really handy. And this is just if you see the list here,
it's actually much bigger than this.
It's a lot bigger now, actually. Yeah, we've got more than 30 agencies now in attendance at the hub. We all dress down. We don't wear badges. That breaks down a lot of barriers, and you can't sometimes differentiate, can you, between who's using the service and who's working there. And it's a really welcoming and friendly place. And when you're there, you truly feel like everybody's in the room with a purpose and the same mindset to make a difference. So the hub in action, we've in 2018 had 1,843 visits to the hub, and all of the users, 100% of the hub users, say they would be worse off without the hub. And it's also beneficial for staff as well and all agencies. There's been a reduction in crime, a 42% reduction seen in crime within the first 12 months of the service being set up. Less ambulances are being called, and the do not attend rate has obviously reduced as well because everybody's in the same room. They're not having to go from different services and have different times. We've had lots of visitors to the hub, including Thames Valley Police. We've had the First Minister for Wales, and they all think the service that we provide is exemplary. And the guys really just say how much the service has changed their life. Everybody looks forward to a Friday morning, don't we? And it's just a really lovely place to work. And that's some of the feedback from the guys. Have we got time to show a little video of one of the guys?
About 3 minutes.
Yeah.
Oh.
Yeah.
I came down here to see my mother, and she was actually in a violent, abusive relationship with a violent partner who had mental health problems, and my mum was taken away from us, and me and my brother had never been on the streets, so we were basically left with nothing and no one, no guidance. And my dad, his daughter had died, so we lost touch with him, and it was basically like, it was just a tragic line of events, really. In our heads we thought family, with some sort of family intervention, but it seemed no family were coming or anything, so we thought, we turned to people on the streets for advice, and if it weren't for people there, I don't think you survive the first night, because there's always something in you. You think, oh, you're not going to make it, you know, you should just end it because you can't, like, go through it. But then you got people there that are smiling and they're like, come on, you know, and they're trying to have a smiley face on you, and you're like, you can't let you just got to keep going through it, you know what I mean? And I remember me probation worker, he had a go at me for being with the homeless, and I said, well, I am homeless, I eat with the homeless, I sleep with the homeless. It's pretty much impossible for me not to associate with the homeless. You know what I mean? We basically had no one, nothing, no accommodation, no family to help us or anything. I felt disowned. I remember my dad said he didn't even know if we were dead. It was horrible, it was. Because your imagination runs wild, doesn't it? And if you're on the streets, and I wasn't even a man, I was 17, I was a kid really. I just wish I never came on the streets. But it was, I don't know. If there weren't the services around, it would be just horrendous. No one would have nothing to go to. You know what I mean? Because we need the food, we need just the care, even people just saying all right to us. You know what I mean? Just so we know that they're there. And this crisis craft, this is really good as well, because you can come to all your appointments in one, and get your food and that, and you got doctors there as well. Because when you don't have your family, that's a horrible thing when you can't come to your family for help, and there's other people there, it's a godsend really, because you think they don't even have to put the time into you, you know what I mean? They're only doing it for kindness, so you appreciate that. The most scary thing I'd say is when you're scared for, you're thinking of all the scenarios that could happen, the possibilities of, you know, when you hear people drunk, and you hear and you hear them fighting, and you hear like people say horrible things like, I'm going to smash a homeless head in, and people who just want to take their anger out on, and they get a horrible fear that's like, oh, you know, like you're thinking that they're going to come in and just kick you or something. Because I've been laying in the doorway and I've had a group of lads walk past, and I've heard them say, oh, shall I kick him in the back? And you're thinking, it's just so horrible how you look at someone like that. Well, I'd say just give them respect, look at them in the eyes, you know, ask them out, just say all right. You don't have to give them money, you don't have to give them anything, just look at them like they're a human being, acknowledge them. Like, don't just brush them off, or just look at them like they're nothing, because that can hurt, you know.
That's it for that part of the workshop. We were going to go through where we're going now.
I think I'm right in assuming this question and answer now. Yeah. So has anyone got any questions for any of the speakers this morning? None? Really? Yeah.
I've got a question for Emma.
Louise Davis from Montgomery Town Council. Just wondered what work was being done in Welsh Government to bridge the gap between housing policy and health policy in terms of pushing the interventions further upstream. Because as you say, the quantum of money going into housing isn't going to change, but turning the other tankers then becomes even more important.
Thanks very much. The short answer is an awful lot. There is a very good policy working relationship with health, and in particular with colleagues in mental health and substance misuse, which are two of the services that we know from a health perspective, under a huge amount of pressure, but are be absolutely fundamental to addressing the complex needs of lots of people who find themselves homeless. So we have a very close working relationship. We are looking jointly now at funding bids and trying to make sure that actually we're pulling in the same direction and looking for the same things in funding bids. We're also having conversations with colleagues in some local authorities about how do we balance out the fact that the fundamental principle of the health service is clinical need, but sometimes we know that actually we need to help people at a certain point in time, and that takes a slightly different service perspective, and looking for how we can fill those gaps in partnership with our health colleagues, rather than it feeling like we're all trying to pull in different directions. So we're not there yet, but I think we're certainly in a very good position from a policy perspective and from a ministerial perspective. The strategic policy statement that I referred to earlier, that actually got full cabinet sign-up, and that was really important to us and to the minister, that actually it was not seen as a housing minister strategy, it's a full government cross-cabinet commitment.
Anyone else? Really? All right, so I guess it's lunchtime.